There are peptide analogues, which are incretins, are insulin secretagogues. The two main candidate molecules that fulfill criteria for being an incretin are glucagon-like peptide, which is called GLP-1, and gastric inhibitory peptide, glucose-dependent insulinotropic peptide (GIP). Both GLP-1 and GIP are rapidly inactivated by the enzyme dipeptidyl peptidase 4 (DPP4). And glucagon-like peptide agonists bind to a membrane GLP receptor. As a consequence, insulin releases from the pancreatic beta cells is increased. Endogenous GLP has a half-life of only a few minutes, thus an analog of a GLP would not be practical. The liraglutide in particular may be considered first line in diabetic patients with cardiovascular disease, as it has received FDA approval for reduction of risk of major adverse cardiovascular events in patients with type 2 diabetes. And exenatide, which is exendin 4, marketed as Byetta, is the first GLP-1 agonist approved for the treatment of type 2 diabetes. Exenatide is not an analog of GLP but rather a GLP agonist. Exenatide has only a 53% homology with GLP, which increases resistance to degradation by DPP4 and extends its half-life. Then we have liraglutide, once daily human analog. 97% homology has been developed by Novo Nordisk under the brand name of Victoza. The product was approved by the European Medicines Agency (EMEA) on July 3, 2009 and by the US Food and Drug Administration (FDA) on January 25, 2010. A 2011 Cochrane review showed a HbA1c reduction of 0.24% more with liraglutide 1.8 mg compared to insulin glargine, 0.33% more than exenatide 10 microgram twice daily, sitagliptin and rosiglitazone. Liraglutide together with exenatide led to greater weight loss than glucagon-like peptide. And then we have the effects of Ayurvedic medications. Ayurveda, alternative medication systems with historical roots in the Indian subcontinent. The theory and practice of Ayurveda is pseudo-scientific. Ayurveda is heavily practiced in India and Nepal. We have found 80% of population report using it. These therapies include herbal medicine, special diets, meditation, yoga, massages, laxatives, enemas, and medical oils. Ayurvedic preparations are typically based on complex herbal compound, mineral and metal substances, and perhaps under the influence of early Indian alchemy. And ancient Ayurveda text is taught in surgical techniques including rhinoplasty, kidney stones extractions, sutures, and extraction of foreign objects. And the main classic Ayurveda text begins with the account of transmission of medical knowledge from the god to the sages and then to the human physicians. Printed editions of Shurashtra Samhita compendium frame the work as the teaching of Dhanvantari, and Hindu god of Ayurveda incarnated as king of Diodasa of Varanasi, to a group of physicians including Sushruta. The oldest manuscript of work, however, omit this frame, ascribing the work directly to King Diodasa. Dada Baba Haridas in the 1970s and Maharishi Ayurveda in 1980s use these medications, and historical evidence for Ayurvedic test help terminology and concepts appear from the middle of the first millennium BCE onwards. But there is no good evidence that Ayurveda is effective to treat or cure cancer or sugar. Some Ayurvedic preparations have been found to contain lead, mercury, and arsenic, substances known to be harmful to humans. A 2008 study found the three substances in close to 21% of US Indian manufactured patent Ayurvedic medicines sold through the internet, and the public health implications of such metallic contaminants in India are unknown. Then we have biguanides, which reduces the hepatic glucose output and increases uptake of glucose by the periphery, including skeletal muscle, although it must be used with caution in patients with impaired liver or kidney function. Metformin, a biguanide, has become the most commonly used agent for type 2 diabetes in children and teenagers among common diabetic drugs. Metformin is the only widely used oral drug that does not cause weight gain. And then we have fenformin. DBI was used in 1960, though in 1980s, but it was withdrawn due to the lactic acidosis risk. Buformin also was withdrawn due to lactic acidosis risk, and metformin is usually the first type-line medication used for treatment of type 2 diabetes. In general, it is prescribed at initial diagnosis as conjunction with exercise and weight loss, as opposed to in the past where it was prescribed after diet and exercise has failed. There is an immediate release as well as an extended release formulation typically reserved for patients experiencing gastrointestinal side effects. It is also available in combination with other oral diabetic medications. Then we have thiazolidinediones, TZDAs, also known as glitazones, bind to PPARY peroxisome proliferator activated receptor Y, a type of nuclear regulatory protein involved in transcription of genes regulating glucose and fat metabolism. These PPARs acts on peroxisome proliferator response elements PPRE. PPREs influence insulin-sensitive genes, which enhance production of messenger RNAs of insulin-dependent enzymes. The final result is better use of glucose by the cells, and these drugs are also enhance PPAR alpha activity and hence lead to a rise in HDL and some larger component of LDL. Typical reductions in glycated hemoglobin HbA1c values are 1.5 to 2%. Some examples are rosiglitazone, Avendia. The European Medicine Agency recommended in September 2010 that it is to be suspended from the European market due to elevated cardiovascular risk. Then is pioglitazones Actos remains on the market, but it has also been associated with increased cardiovascular risk. Then is proglitazone Rezulin, used in 1990s, withdrawn due to hepatitis and liver damage risk. Multiple retrospective studies have resulted in a concern about rosiglitazone safety. Although it has established that the group as a whole has beneficial effect on diabetes, the greatest concern is an increase in the number of severe cardiac events in patients taking it. The adopted study, ADOPT study, showed that initial therapy with drugs of this type may prevent the progression of disease, as did the DREAM trial. The American Association of Clinical Endocrinologists, AACE, which provides clinical practice guidelines for management of diabetes, retains thiazolidinediones as recommended first, second, or third line agent for type 2 diabetes mellitus, as of their 2019 executive summary over sulfonylureas and alpha-glucosidase inhibitors. However, they are less preferred than GLP-1 agonists or SGLT2 inhibitors, especially in patients with cardiovascular disease, with which liraglutide, gliflozin, and canagliflozin are all FDA approved to treat. Concerns about the safety of rosiglitazone arose when a retrospective meta-analysis was published in the New England Journal of Medicine. There have been a significant number of publications since then, and Food and Drug Administration panel voted with some controversy 20-3 that available studies supported a signal of harm, but voted 22-1 to keep the drug on the market. The meta-analysis was not supported by an interim analysis of the trial designed to evaluate the issue, and several other reports have failed to conclude the controversy. This weak evidence for adverse effects has reduced the use of rosiglitazone despite its importance and sustained effects of glycemic control. And Proactive 5 has shown that pioglitazone may decrease the overall incidence of cardiovascular events in people with type 2 diabetes who have already had a heart attack. Then we have LYN, line kinase activators. Line kinase activator tolimidone has been reported to potentiate insulin signaling in a manner that is distinct from the glitazones. The compound has demonstrated positive results in a phase 2A clinical study involving 130 diabetic subjects. And now I will give you some knowledge about sulfonylureas which are coming by the name of glibenclamide. Glibenclamide is known as glyburide, which is an anti-diabetic medication that is used to type 2 diabetes, and it is recommended that it is being taken together with diet and exercise, and it may be used with other anti-diabetic medication. It is not recommended for use by itself in type 1 diabetes, and it is taken by mouth. Glibenclamide was discovered in 1969 and approved for medical use in the United States in 1984. It is available as a generic medication, and in 2022 it was the 200th most commonly prescribed medication in the United States with more than 2 million prescriptions. But as you know, there are side effects. Frequently reported side effects include nausea, heartburn, weight gain, and bloating, hypoglycemia, and the risk is greater than with the other sulfonylureas. Glibenclamide may not be recommended in those with G6PD deficiency, and it may cause acute hemolysis. And pregnancy and breastfeeding, it is generally not recommended during pregnancy but can be used during breastfeeding. Then we have gliclazide, sold under the brand name of Diamacron. Among others is the sulfonylurea type of antidiabetic medication used to treat type 2 diabetes. It is used when the dietary changes, exercise, and weight loss are not enough, and it is taken by mouth. And it has a molar mass of 3 to 3.41 g mole, and it has some side effects that include low blood sugar, vomiting, abdominal pain, rash, and liver problems. Used by those with significant kidney problems or liver problems or who are pregnant is not recommended. Gliclazide is in the sulfonylurea family of medications, and it works mostly by increasing the release of insulin. Gliclazide was patented in 1966 and approved for medical use in 1972, and it is on the World Health Organization list of essential medicines. It is not available for sales in the United States. There are some adverse effects which are hypoglycemia, and the European guide study has shown that it has approximately 50% less hypoglycemic confirmed episodes in comparison with glimepiride. Then the glimepiride is an anti-diabetic medication used to treat type 2 diabetes. It is less preferred than metformin. Use is recommended together with diet. And the glimepiride is sold under the brand name with the combination of pioglitazone and glimepiride by the brand name Diabetic. Among others is a fixed dose combination and anti-diabetic medication for the treatment of type 2 diabetes. Gliclazide and is a sulfonylurea type drug and considered as a second generation agent of sulfonylurea type drug. Chlorpromamide second generation agent, glipizide, glyburide or glibenclamide, glimepiride, glyclazide, hypoglycemide, glycuride, meglitinide helps the pancreas produce insulin, and in type 1 diabetes is caused by the lack of insulin, and insulin must be injected, and in type 2 these type of medication can be used. The great advantage of injected insulin in type 2 is that as well-educated patient can adjust the dose or even take additional doses when blood glucose level measured by the patient, usually with a simple meter needed by measured amount of sugar in the blood. Then there are some sanitizers which are biguanides, which reduces hepatic glucose output and increase the uptake of glucose by the periphery, including skeletal muscles. Although it must be used with caution in patients with impaired liver or kidney function. Metformin, a biguanide, has been the most commonly used agent for type 2 diabetes. And in the last, I will end my topic with the quoting that among common diabetic drugs, metformin is the only widely used oral drug that does not cause weight gain, and typical reduction in glycated hemoglobin A1C values for metformin is 1.5 to 2.0%. Metformin may be best choice for patients who also have heart failure, but it should be temporarily discontinued before any radiographic procedure involving intravenous iodinated contrast, as patients are at increased risk of lactic acidosis. And fenformin and buformin were withdrawn because of the risk of lactic acidosis. Metformin is usually the first-line medication treatment for diabetes, type 2 diabetes, and in general it is prescribed as an initial diagnosis in conjunction with exercise and weight loss, as opposed to in the past where it was prescribed after diet and exercise has failed. There is an immediate release as well as an extended release of formulation, typically reserved for patients experiencing gastrointestinal side effects. It is also available in combination with other oral diabetic medications. I hope so that you have gained a lot of information about diabetic medication in this topic, and it will be very helpful for you, and I hope so that you have enjoyed this video. So please don't forget to subscribe it, and thank you for listening my video. Have a wonderful day.